All right, so let's take everything that you've been learning in this unit and apply it to your clinical practice. We will start with anemia. So remember that there are there are two different lines that the production of blood cells can come from. Either, and of course they all start with the hematopoietic stem cell, but it can either go into the lymphoid progenitor, which gives rise to B cells and T cells and natural killer cells, or it can go down the myeloid line, which produces things like red blood cells, megakaryocyte and platelets, mast cells, basophils, EOs, which are associated with allergy, neutrophils, which are associated with phagocytosis and fighting infection, and then, of course, macrophages, which come from monocytes. So remember, the monocytes float through the blood. They deliver themselves to the tissue through the wall of the vessel in a process called diapedesis. They squeeze through the vessel wall, and then they live in the tissue. So there's different types of tissue macrophages. There's splenic macrophages that live obviously in the spleen. There are Kupffer cells in the liver. There are, I forget what the name of the ones in the skin are, but they're in the lungs, the skin, they're everywhere, okay? GI tract as well. So those are the methods, or the two cell lines, the common lymphoid progenitor, which gives the T cells and B cells, and the myeloid line that gives the macrophages, the white cells, the platelets, and the erythrocytes. I left out this important thing, and I want to remind you of this very important cell, so I gave you a description here to read. Remember, the dendritic cell is important because it is the one that ties together innate immunity and the adaptive immune response. And when these dendritic cells are exposed to a new antigen, they become one of the three antigen-presenting cells that notify the T lymphocytes, right? The T lymphocytes that will go and destroy things. So let's just keep this as simple as we can as we talk about erythropoiesis, or erythropoiesis if you prefer. What is it that drives red blood cells to be produced? Or what is it that drives the bone marrow to produce new red blood cells? Well, the first thing is hypoxia. So it's this hypoxia that happens and is sensed at the tissue level that causes erythropoietin production. When the erythropoietin is released, that increases the bone marrow production of red blood cells. Okay, how do we get red blood cells? Well, remember that most iron used in red blood cell production comes from old RBCs. We can't absorb enough dietary iron to make new red blood cells at the rate that we need to. So we have to reuse a lot of iron from old red blood cells. And those old red blood cells are, they last somewhere between, I learned 90 to 120 days, but newer sources say 100 to 120 days. So when someone has chronic blood loss from colon cancer or some other problem, they can develop iron deficiency anemia. And why do they have that? Well, because they can't absorb enough iron in their diet. It's just impossible. And I'll show you later on what the actual numbers look like. And then finally, we use B12 and folate to construct the red blood cell. And when the B12 and folate are deficient in the diet, then we end up with big, ugly, weirdo-looking red blood cells that don't work as well. Okay, we'll talk about them too. So remember, erythropoietin, sorry I didn't erase that, erythropoietin comes from decreased tissue oxygenation. So it can be because of low blood volume, which is what you would think when we're producing new red blood cells as a result. But it could also be because of poor blood flow, right? Could be poor cardiac output that makes it happen. At the tissue level, if there's not enough oxygen getting to the tissue bed, that is sensed and erythropoietin is released. The other thing is pulmonary disease, and this is why you end up with higher levels of red blood cell production in patients with advanced COPD, why their hemoglobins are much higher. Okay? So what's required for RBC production? Well, a whole lot of iron. In fact, about 20 milligrams of iron per day is required for red blood cell production. And to mature those, we need, again, B12 and folate. Iron transport and metabolism happens with different forms of iron. So free iron is Fe2+. Ferritin, which is the storage form, is Fe3+. Okay? Transferrin, probably doesn't surprise you that transferrin is the movement form. What's the word I want? Transport form. Sorry, I ran out of room. Transport form of iron. And that transferrin goes through the plasma and then is used to create new red blood cells. And remember, importantly, bilirubin is one of the byproducts of breakdown of hemoglobin and the release of free iron. So when we're looking for information about the rate of breakdown of red blood cells, as we would in hemolysis or hemolytic anemias, we look to the bilirubin to help us. Okay? So this is the iron information that you'll have to know. You remember that iron is required for synthesis of hemoglobin. The lack of iron or an iron deficiency, just like if you don't have bricks to build your brick building, you can't build it. Well, the same thing happens when there's iron deficiency. If you don't have enough iron stores or enough free iron circulating in the blood, then you can't build red blood cells. So that will affect the rate of production. Remember that iron doesn't dissolve very well in the blood, and it has to be affixed to carrier proteins, and those again are ferritin, which is the storage form, and transferrin, which is the transport form of iron. So again, just by the numbers, so you believe me that we have to use iron that is taken from old used red blood cells. These are the numbers. Total body iron is about 3 or 4 grams. Your daily iron needed to make new red blood cells is about 20 milligrams, but you only absorb 1 to 2 milligrams. So only 10% of what you need are you absorbing from your diet. The rest of it is being recycled. Okay, and we talked about transferrin. There's something called transferrin saturation, which is how much of the transferrin molecule, remember that transferrin is just the protein part that picks up the iron. How much of that is saturated? How actively is it working? That's a measure of that we use when we're talking about anemia. And then ferritin, as we discussed earlier. Remember, hemoglobin is made up of an alpha subunit and a beta subunit, and the disease, when there is not enough, or I'm sorry, when there's an abnormality of the alpha or the beta subunit, we call that thalassemia. So there's alpha thalassemia or beta thalassemia. We don't encounter that a whole lot. It's not something that you're going to run into with great frequency. At least I haven't in my clinical practice. So we'll skip over that. We're also going to skip over the iron cycle, but the details are here. It involves the liver, it involves the spleen, it involves the gut, and of course, it involves the bone marrow. So there are 3 reasons that you can have anemia. You can have a decrease in red blood cell production. Maybe we don't have enough iron. Maybe there's a problem with the bone marrow, right? There are different reasons that you can have decreased red blood cell production. There may be an increased red blood cell loss, and that's the second thing. Loss of red blood cells. So bleeding from occult malignancy or hemolysis. Maybe there's an autoimmune hemolysis going on. Maybe the patient has malaria, which, if you remember, the malaria sites, I forget what they're called, the little organisms, plasmodium, something or other, they use red blood cells to reproduce, and so there's hemolysis that happens in malaria. Drugs can do it. The spleen being overactive can do it. There's all sorts of other ways, but hemolysis is one of the primary reasons that we can end up with anemia as well. The third general way is that we have broken red blood cells being produced. So sickle cell anemia is a possibility, or probably the most commonly known of those broken RBCs. So let's talk about the laboratory testing for anemia. We have the CBC and, of course, the differential with the CBC, or the red cell indices. The serum iron measurement, the ferritin, which is the storage form. I'm going to keep hammering that into your head. And the transferrin, which is the transport form. Transferrin, you get it. The transferrin saturation, which is different than total iron binding capacity. The transferrin saturation is actually the serum iron divided by the total iron binding capacity times 100. What's the total iron binding capacity, you may ask? Well, it's the transferrin times 1.389. Okay? So you're going to hear these terms. Different clinicians prefer different measures. The transferrin saturation seems to be superior to total iron binding capacity. I don't exactly understand why. The thing that I encounter most frequently is total iron binding capacity, but I'm going to help you to think these things through in a couple of slides from now. Finally, of course, we have folate and B12, which help to construct the red blood cell appropriately. These are the levels that you should expect. And remember that the red blood cell indices are the calculations that are done to tell us about things like size. Okay? Size of red blood cells is calculated from the mean corpuscular volume, or is known from the mean corpuscular volume, and it's calculated that way. The mean corpuscular volume, you think about it, you put a volume of basketballs into a pool, you're going to have fewer of those basketballs that fill the pool than if you put golf balls into a pool. It's going to take a lot more golf balls. So we can assess size or infer size by volume. Okay, there's a one-to-one, there is a known relationship between those two. The second, and by the way, when the cells are small, then it's microcytic. When the cells are too big, it's macrocytic. And when they're just right, then they're normal. Then we talk about the color of red blood cells. And the color we get from the mean corpuscular hemoglobin concentration. So the amount of hemoglobin, which is red, the amount of hemoglobin that is in the red blood cell is a function of the mean corpuscular hemoglobin concentration. That's what we use to measure it. And so when it's low, it's hypochromic. They look pale under the microscope. And hyperchromic is they're darker. So there's also classic characteristic appearances in anemia. So these microcytic cells look like this. Sickle cell anemia, of course, has the sickle cell shape, right? Megaloblastic anemias have these giant red blood cells. Look at them compared to these microcytic ones. Very different sizes. Okay? And erythroblastosis fetalis, I do not remember what that is, so we're going to skip that anyway. I don't encounter that in grown-ups very often. Ever, actually. Okay? The bilirubin is elevated, so that's important to look for. And it's the conjugated bilirubin or direct, that is elevated. And the red cell count, the hemoglobin, hematocrit are all decreased. The reticulocyte count is increased. And remember what reticulocytes are. They are the red blood cells that still have some organelles left. And that just means that they're being released into battle as late teenagers instead of fully grown adults. Okay? We may see RDW increases in hemolytic anemia. The blood smear, we see this. This is a blood smear, right? So we see schistocytes, and we see an elevated iron level because those red cells are being broken down, and we see LDH levels that are increased. Okay? We don't see hemolytic anemia often I don't in my business. But it's easy to recognize when you see an increased conjugated bilirubin and anemia, and then we can look for retic counts, and that's a pretty easy conclusion to draw. So let's talk about the approach to laboratory testing. This I took from UpToDate, and you can see, you can click right down here on the UpToDate article. It's very long, but I have abbreviated it for you. First of all, if you see pancytopenia, which is decreased white blood cells, decreased hemoglobin, and decreased platelets, then you have to think about causes of pancytopenia, because it's not just anemia at that point. It could be they have drug-induced pancytopenia, could be viral or non-viral infections, could be bone marrow suppression, whether it's from drugs or from cancer or some other malignancy. All of those things need to be taken into consideration, as do overactive spleen, autoimmune diseases, and all these other things. So pancytopenia, if you see all three are low, that's a different animal than anemia. All right. So for anemia, we're going to start with the CBC and focus on the MCV. The MCV, when it's increased, that suggests, right, those are giant red blood cells, that suggests folate or B12 deficiency. If it's decreased, that suggests iron deficiency. So microcytic anemias are most often iron deficient anemias. Okay? A reticulocyte count is also helpful because when it's elevated, that goes along with blood loss or hemolysis. Essentially, this means increased bone marrow production. All right? So when there's increased bone marrow production, that increases the reticulocyte count. Those red cells are released into battle just a little young, but they can still function as red blood cells and carry oxygen. When it's normal or low, the retic count that is, there may be a red blood cell production problem, and that could be bone marrow related. So if it's microcytic, then we get iron studies, all right? And if the retic is elevated, then we're going to check haptoglobin. If the haptoglobin is reduced, then that suggests hemolysis, because haptoglobin binds with hemoglobin in order to reuse the iron. And then, of course, we get a peripheral blood smear. But this is the basic approach to laboratory testing. I want you to focus on this and memorize this, because this is an important thing that you're going to have to use daily in your career. Well, maybe not daily, but several times a week for sure. So the diagnosis of iron deficiency anemia is made from microcytic hypochromic anemia. The transferrin, which is the transport form, remember it's the protein that will transport the iron, is increased. Now, does that make sense? Well, yeah, because there's more of it waiting around to take iron elsewhere, right? To be used. The transferrin saturation, the amount of iron that's saturated on the transferrin molecule, is decreased. Does that make sense? Yeah, that makes sense because there's not enough iron to attach to the transferrin molecule to move it through the blood. Okay? And then, of course, ferritin is decreased. And ferritin is storage form. And so when the ferritin is decreased, that happens because there's not enough iron to put into storage. All the iron that's around is being used to make new red blood cells. Okay? Makes sense? So once we begin this process of looking at anemia, we often come up with the conclusion that people have iron deficiency anemia. But in the population that we work with, remember you are adult gerontology, not just adults, but adult gerontology acute care nurse practitioners. And that means we deal with the older population quite a bit. And when we do, we end up having a lot of patients who have this anemia of chronic disease. Okay? Now, sometimes this is associated with iron deficiency, but normally it is a normocytic anemia. I'm sorry. I want to throw in here the kidney issue too. So anemia of chronic disease is its own thing, but another anemia that we see in older patients is related to kidney failure. So when we see a normocytic anemia with a GFR less than 45, okay, so that makes them CKD3A, or I'm sorry, well, it's the borderline of A and B, right? So CKD stage 3B with a normocytic anemia is probably anemia of chronic disease, the renal type, okay? So when we find this anemia of chronic disease, we evaluate for the disorders that are common, because sometimes it's not just from a chronic disease that we don't want to investigate. Sometimes we need to look for monoclonal gammopathies. We need to look for androgen deficiency in men, bone marrow evaluation for myelodysplasia, etc. Okay? This is the important thing I want you to notice, though. Notice that in iron deficiency anemia, we see the ferritin go down and the transferrin go up. Okay? That's iron deficiency anemia. Ferritin is down because there's less iron, and the transferrin, or the capacity to bind iron, is up because there's not enough iron filling it. But look what happens in the anemia of chronic disease. That's very different. The ferritin is up and the TIBC, or the transferrin, is low. So that's complete opposites. And this is the thing that will help you to differentiate iron deficiency anemia from anemia of chronic disease. Okay? So we found somebody who's anemic. We begin to work them up, but how do we know when to transfuse them? Well, one of the things I want to do with these lectures is to help you evaluate the guidelines. So the AABB, that's the American Association of Blood Banks guidelines from 2012, show the following. First, In hospitalized, hemodynamically stable patients, at what hemoglobin concentration should a decision to transfuse be made? Well, in adult and pediatric ICU patients, okay, adult ICU, transfusion should be considered at hemoglobin levels of less than 7 grams. Okay, 7 grams or less. In post-op surgical patients, however, it should be considered when the hemoglobin is less than 8. Or if they are symptomatic, they have orthostasis, they have chest pain, hypotension, tachycardia, they don't get better with fluid resuscitation, they get heart failure. Those are reasons to transfuse them to greater than 8. Okay, and this is high quality of evidence, and the strength of recommendation is strong. Now, what about patients with pre-existing cardiovascular disease? Well, for those patients, the recommendation is to keep their hemoglobin more than 8. Now, the quality of that evidence is not great. It's moderate, and the strength of the recommendation is kind of weak, right? But in clinical practice, in cardiology, we strongly adhere to this. We don't want people to have a hemoglobin less than 8 without really good reason. In hospitalized hemodynamically stable patients with acute coronary syndrome, at what hemoglobin level should we transfuse? Well, there is no recommendation about that. That study has not been done, or there hasn't been enough convincing evidence, so there is no recommendation. And then finally, in hospitalized hemodynamically stable patients, should transfusion be guided by symptoms? Well, it turns out that is their recommendation. So the AABB suggests that transfusion decisions be influenced by symptoms. The quality of evidence is low, and the strength of the recommendation is weak, but that's what we go on. All right, so those are the guidelines that we use for transfusion. Typically, we like to keep the hemoglobin greater than 7. Hemoglobin greater than 7. On the hem-onc unit or on the oncology unit, they tend to favor a hemoglobin of 6 to transfuse. They try to let people get by with a lower hemoglobin, but again, for us, so this is normal. For us with CV disease, we want a hemoglobin greater than 8. Okay, that's what we go by. All right, let's talk about 2 kinds of hemostasis. First, we'll talk about platelets. And remember, the platelets are the first thing that happen, right? So the very first thing that happens when there's a severed vessel or damage to the endothelium, platelets agglutinate, they show up, they aggregate, they stick together, and they form the white clot. Then the fibrin part appears, and the fibrin gets laid down around the platelets, and the red blood cells get trapped in there. Eventually, you get a fibrin clot. That fibrin clot allows healing to take place. After a few days, the healing has taken place, and then the clot begins to retract. And how does that happen? Well, because plasminogen gets activated, and that starts to break down the clot. Okay? The summary of platelet function is shown here. Remember that we have cyclooxygenase in the arachidonic acid pathway that eventually gives rise to thromboxane A2. And that is one of the things that activates platelets. And the thing that works against that is prostacyclin 2, so PGI2, that is healthy endothelium, and that is responsible for vasomotion and nitric oxide production and all those other things. All right? So review the platelet roles in hemostasis because we need to talk about antiplatelet therapy because we use it a lot, right? We use it for prevention of MI and strokes, or what I call the vascular stuff, right? We use it to prevent vascular events. Now, what's the difference between primary and secondary prevention? Well, you remember primary prevention is where we're trying to prevent a first heart attack or stroke. Secondary prevention is where somebody already has established coronary disease and we're trying to prevent a stroke or MI after they already have established disease. Okay? So we use antiplatelet therapy in primary prevention, secondary prevention, but we also, and most importantly, we use it following PCI. All right? The downsides of antiplatelet therapy, of course, are increased bleeding risk, but some of these agents are really expensive. So Plavix, when I last looked, is about $1,000 a year, cash pay, and Brilinta is about $6,000 per year. $6,000 per year. It's insane, right? And it's a little bit better than Plavix. Little bit better. I don't know that it's $5,000 worth better, but those are the agents that we use. Okay? You may have heard recently there was a lot of hullabaloo about the United States Preventive Services Task Force, USPSTF, and you can click here to get the report. But they came out with a statement that they do not recommend aspirin as primary prevention in people who are over 60 years of age. And they said that, and then suddenly we heard some other thought, well, maybe you should just talk it over with your doctor. So the current recommendation is that they can't recommend it based on the evidence, but you should talk it over with your doctor rather than just stopping it. Well, the reason that they can't recommend it is because it's not hugely effective. It certainly doesn't prevent coronary disease, but it makes it more likely that your first event will be an episode of unstable angina rather than an acute MI. That's the hope anyway. But there's a cost for that, and that cost is bleeding. Bleeding is the cost. Okay? That's also true after PCI. And so I just wanted to give you a quick and dirty understanding of how we got to where we got today. So back in the 1980s, when I started doing all this, balloon angioplasty, or PTCA, was the big deal. Percutaneous transluminal coronary angioplasty. But it had some problems. It had a relatively high abrupt closure rate, somewhere in the 10 to 15% range, if I remember correctly. And there was about a 30% chance of restenosis. And that restenosis happened within 3 months. There was also late restenosis where there was narrowing of the artery again within a year. But typically when it happened within the first 3 months. So 3 months. And the remedy for that was just to redo the PTCA. In the early 90s then, we came out with these bare metal stents, and the Cook stent was the first one. The Cook stent was the first one, and then the Palmaz-Schatz stent we thought was just the greatest thing in the world because it didn't have quite as high of a abrupt closure rate, but the restenosis rate was still bad. So the fix for that was ballooning the stent again. In the mid-90s then, we started to see just too much of this, and we figured that when we took patients to the lab who had a stent in, we were seeing clot in there. There were filling defects all over the place. So then we started anticoagulating patients. And I remember one particular disaster where a patient almost ended up losing her leg as a result of this anticoagulation that we were doing. It was quite a mess. And still, we didn't really budge on the restenosis rate with these stents. Later, and also we used radiation. So if people continued to have restenosis because of thickening of the intima, we did brachytherapy on them, and we just irradiated their chest. I thought that was a horrible idea, because what if they need bypass? Then you're going to be sewing into mush, but whatever. We didn't last long with that, because later in the 90s, we discovered that antiplatelet agents, and in particular DAPT, dual antiplatelet therapy, was more effective than anticoagulation, and we often didn't need brachytherapy. Then came the first of the drug-eluting stents. Around 2003 was when the first drug-eluting stent came out, and that made our abrupt closure rate very low and our restenosis rate very low as well. But it required dual antiplatelet therapy. And what if somebody had dual antiplatelet therapy and AFib? Well, back then, we were still putting them on Coumadin plus aspirin plus Plavix, and there were a lot of complications from that. Everybody thought that by the time the 2010s came around, we would be using these dissolvable stents. Well, it turns out in 2017, studies came out showing that they were not a good idea, that people ended up needing re-intervention if they got dissolvable stents, and so that was a problem. So they went the way of the dinosaurs, and we are no longer using dissolvable stents. Fast forward then to the 2020s, where we have the second generation of drug-eluting stents. We have a very low abrupt closure rate and a very low restenosis rate. And now we're using DAPT for 6 months at a minimum, and preferably 12 months. The future and the studies that are going on right now are to test an aspirin-free monotherapy for a shorter duration. So we need to figure out what is the least amount of time that we can safely put people on antiplatelet therapy, and can we do it without aspirin so that we don't have that risk of eroding the stomach wall. So that's sort of the down and dirty of stent history to bring you up to date. These are the studies that were done, and I have a link down here for you to click on if you're interested in learning more about that. Okay, so what is it that these stents do, and how's a bare metal stent different from a drug-eluting stent? Well, when you have a stent in there, you have this muscular hyperplasia that happens. That presence of that stent increases the musculature in the media, the medial layer of the vessel, and that can be a problem. It's also pro-inflammatory, and that inflammation leads to an increased endothelialization. Okay? So when you put the stent in, it injures the vascular endothelium, and the response is that the endothelium grows inward. Well, what was happening with these bare metal stents is that they would continue to grow inward, and we would have restenosis. Okay? When we had abrupt closure, that was from clot, right? That was from clot. And we didn't really see that after we figured that out and anticoagulated people during the procedures. But we still had restenosis. And I missed the S at the end there, sorry. So that restenosis happens because that endothelial hyperplasia and the muscular hyperplasia makes the vessel grow inward, and it closes the vessel off. So we came up with the drug-eluting stent. And I say we, but I didn't really have anything to do with it. But the drug-eluting stent decreased the reendothelialization. So it still happens, but because we're giving an anti-immune drug, it slows down that process a lot. And that bare metal stent is still exposed for 3, 4, maybe 6 months, maybe up to a year. That's why we do the antiplatelet therapy for so long. So with a bare metal stent, we have a minimum of 30 days until that endothelialization happens. And with the drug-eluting stents, we have less of this hyperplasia, but we have less endothelialization or reendothelialization. It slows it down so it's less thrombotic. Okay? So today we plan our antiplatelet therapy based on the likelihood of restenosis. And the likelihood of restenosis is higher when there's complex PCI, when we're implanting older generations of stents, if they had prior stent thrombosis, and if they have clinical features like diabetes, CKD, if they've ever had an ischemic event post-PCI, and certainly if they have vascular disease. All right, so these are the rules that we use today for dual antiplatelet therapy following PCI. If you have an average bleeding risk and an average ischemic risk, you get 6 to 12 months of DAPT with aspirin, plus either clopidogrel or Brilinta in some labs, followed by aspirin monotherapy once a day. All right, so after 6 to 12 months, then you go to aspirin once a day. If you have a high ischemic risk and an average bleeding risk, then this is the thing that we tend to do. All right, again, this is from Up to Date. You can reference that for more details. Let's talk about hemostasis. Remember, there's an intrinsic pathway and an extrinsic pathway, and you can familiarize yourself with these. I'm not going to go through it, but remember, at the end of the day, we have the final common pathway. The final common pathway is where thrombin is produced, and those fibrin fibers get cross-linked and form a clot. Okay? And so here are the steps in that final common pathway, and you're welcome to memorize those if you like. Remember that there is this check and balance system in clot formation. So whenever we see unnecessary clotting, that is abnormal. There's something bad going on, whether it is a genetic trait like protein CNS deficiency, antiphospholipid syndrome, factor V Leiden, something is wrong, or DIC or something like that. Any unnecessary clotting is pathologic. Okay? The way that your body prevents overclotting is with these strategies. All right? So healthy endothelium, as exists in non-diabetics, non-hypertensives, people who don't have coronary disease, there are many molecules that inhibit the platelets and the clotting cascade proteins, and they are the checks and balances of clotting. Okay? Also, the plasmin system lyses clots once the tissue has healed. So that also works against the clotting system. Tissue factor pathways, the proteases, the cofactors, all of these things are restraints against clotting. Remember that healthy endothelium inhibits clot formation. And so we know that diabetics in particular have terrible endothelial function. Their vasomotion of the endothelium is impaired. They don't release significant amounts of nitric oxide, prostacyclin, proteoglycans, thrombomodulation or thrombomodulin, whatever that is, or tissue factor inhibitor. All of those things are impaired when you have endothelial dysfunction. Interestingly, when we put patients on ACE inhibitors, that improves endothelial function. So ACE inhibitors and probably ARBs in most instances are magic medicines that do different things. One thing they do is treat blood pressure. Not great, but they're okay. They reduce afterload. Not great, but they're important in heart failure. They stabilize endothelium. And guess what else they do? They protect the kidneys in diabetes. You knew that. But the coolest thing that they do is they decrease the chance of you even developing diabetes. Nobody understands that, but it was first seen, or at least first noted, I think, in the trials with ramipril, called the HOPE trial. HOPE. And there were several different phases to the HOPE trial. So endothelial function is so important. When you have terrible endothelial function, so when it's poor or terrible, we have increased clotting, increased propensity for clotting, increased events. All right, more heart attacks, strokes, etc. So make sure everybody is on an ACE or an ARB. Don't forget the resolution of clotting. This plasminogen stuff has to be activated to produce plasmin, and then the fibrin clot begins to break down. And that's a great thing because it restores blood flow after the initial event, after all the healing has taken place. All right, so where are the sites that these anticoagulants do their thing? Well, the heparins and the heparins being the unfractionated heparin and low molecular weight heparins all have their function at these places with the red box. Okay. What do you notice here, though? Vitamin K antagonists have their function here at the blue. And where does everything come together? It comes together right here. Or here at factor 10, right? But the activation of factor 10, which is now activated 10 or factor 10A, this is the final common pathway. And this is where all of these drugs try to have their effect. So what do we like about these drugs? Well, we like heparin because it's IV and we can use it easy. We like low molecular weight heparin because it's weight-based and we don't have to measure PTT, right? We like the vitamin K antagonists because they're cheap. That's Coumadin. That's about the only thing we like about it. It's also better than some of these direct thrombin inhibitors and factor 10 inhibitors. It's more effective in higher thrombogenic diseases. So we still use Coumadin. And then we love the direct thrombin inhibitors or factor 10 inhibitors because we can just give a known dose and we know that they're anticoagulated. We don't need to measure the INR. Okay, so this part, final common pathway, we use for these indications. Okay. Don't forget Virchow's triad. If you have these three conditions together, endothelial injury, venous stasis, and hypercoagulability, that is favoring pathological clotting. So I thought I'd put the guidelines for COVID-19 up here, and I'll let you look at them. The guideline for critically ill and acutely ill adults that were written in 2021, and again, you can access that right here. Say that we should use prophylactic intensity anticoagulation. So at prophylactic doses. So 30 or 40 milligrams of Lovenox once or twice a day, less intense therapy is what was recommended. But last year, or this year I should say, this year a study came out that said acutely but not critically ill patients without suspected VTE did better with therapeutic intensity anticoagulation. So now we anticoagulate those people intensively. Now, what did not show was the critically ill. We did this in this study. We saw that the critically ill did not benefit from therapeutic intensity anticoagulation. And so, why do you think that happened? Well, I think it's reasonable to conclude that those patients were so sick that nothing we did was going to help them, right? And I think that's what most of us believe from reading those studies, that if you're acutely ill but not critically ill, you benefit from therapeutic intensity anticoagulation. That's the best treatment method. If you are critically ill, you did no better, probably because you're too sick to benefit from it. So how do we go about selecting an agent for venous thromboembolism? This is an article from the Journal of the American College of Cardiology. You know, this is a resident and fellow publication. It doesn't have the latest and greatest science, but it has great review articles, and this is an example of that. This is it's based on the AHA guidelines, which are impossible to read, right? But this will show you how we like to use different anticoagulants and the duration that we use them for. So essentially, we use anticoagulant for VTE for patients who have a high risk of recurrence, like they're immobile, or they have cancer, or they have COPD, or they're men, overweight, low HDL. I don't understand that one, and I didn't read enough to figure out why. I don't know if anybody knows why. Family history of VTE, thrombophilia, elevated D-dimer, even after anticoagulation is discontinued, and failure to recanalize leg veins after anticoagulated for DVT. Those are people who are at high risk and get lifelong anticoagulation. Okay? So, first we determine the phase of treatment. If this is an initial thing, the patient was involved in a car accident, they ended up getting a VTE, or they ended up getting a DVT and pulmonary embolism because of some leg injury or something, that should get better, and we will only need to address the initial and primary phases, and they shouldn't need anticoagulation for the secondary phase unless they have any of those. Okay? So we reassess for recurrence, and if they have a very low rate or potential for reoccurrence, because they meet these criteria, then they don't get secondary phase. But if they have cancer or have high risk of reclotting, as shown in that list, then they're going to be on lifelong anticoagulation. And the agents that we use are shown here, and they all have very similar uses here. Okay? VKA, by the way, is Coumadin, vitamin K antagonist. So let's talk about anticoagulation for atrial fibrillation. I'm sure everybody knows about the CHA2DS2-VASc score. We've been through several different permutations of this. It used to be the CHAD score. There didn't used to be the twos associated with it. And by the way, I need to take out a couple of these, right? So there's not 2 points for that. And there's not 2 points for sex. So you do get extra points for A, which is age, right? So you get extra point for age, and you get extra points for previous stroke. Okay? So CHF history, CHF history gets you 1 point. Hypertension gives you 1 point. Age is broken down by less than 65, 65 to 74, and then greater than 75 gives you 2 points. Diabetes gives you a point. Sex, female sex gives you a point. History of stroke gives you 2 points. And then any vascular disease, including coronary artery disease, peripheral arterial disease, cerebrovascular disease, any of those vascular disease histories give you a point. And when we do that CHA2DS2-VASc score, we add it all up. I just use, well, by now I've learned it, but I just use the MedCalc app. There's others out there, but that's the one that I end up using. Okay. And then that tells us what their risk of stroke per year is due to their atrial fibrillation. So it's not their lifetime risk of stroke, it is an annual risk of stroke. So theoretically, if you have an annual risk of stroke of 2.1% over 10 years, that's a 21% risk of stroke, right? Because they're additive. We have to take into account their potential for bleeding, however. And so another scale that we use is has bled. And has bled gives you points for hypertension, renal disease, liver disease, history of stroke. Notice that goes both ways, right? Prior major bleed or disposition to bleed, like, for instance, sorry, it's all getting messed up now because I had to touch the screen. Predisposition to bleeding, like AVMs, arteriovenous malformations. Labile INR, you know, those patients who we put on Coumadin and their INR is 12, and then we play around with it and their next INR is 1.1, and it just is a continual nightmare. Age is also a factor here. Medications that predispose to bleeding, like DAPT, right? Or aspirin alone. And of course, heavy alcohol use. So those are the things that go against wanting to anticoagulate somebody for atrial fibrillation. And we just have to weigh the risks and benefits. Okay, but that'll help you to do it. Here are the indications for anticoagulation in atrial fibrillation. These are from the ACC guidelines. They're pretty dense, but I gave them to you here to read if you're interested. We have the recommendations for selecting the right anticoagulant regimen. Also, the references there for you to select if you choose. And then we have potential contraindications to anticoagulation. So what are the potential contraindications? Well, if you have active significant bleeding, we're not going to anticoagulate you, right? Makes sense. I'm not going to try to assassinate you. If you have a severe bleeding disorder, that's a reason not to anticoagulate. Always remember this one, severe thrombocytopenia. So a platelet count of less than 50,000 is an absolute contraindication to anticoagulation. Okay? It's an absolute contraindication. Major trauma is a relative contraindication, depending on how long ago and etc. Invasive procedure or obstetric delivery, previous intracranial hemorrhage, have to be very careful about that, intracranial or spinal tumor, neuraxial anesthesia, which is, epidurals and things like that, and severe uncontrolled hypertension. More guidelines available at Up to Date. But I hope that was helpful to you in thinking more about the hematology content and understanding how you're going to use it in your clinical practice.